Hello and welcome to today's session, Data Interoperability, Your Key to Effective Collaboration. My name is Melissa Giampetri, and I am the Behavioral Health Specialty Director with Nextgen Healthcare. This session today is brought to you by Integrated Care Online, powered by Nextgen Healthcare. If you have any questions during the presentation, please submit those questions electronically using the questions panel on the right-hand side of your screen. Everyone except for our speakers will be on mute during the duration of the webinar. The webinar is being recorded and will be emailed to you and available on Integrated Care Online within just the next couple days. So interoperability is really a key or a cornerstone of healthcare reform efforts, as it enables interdisciplinary teams across community health, behavioral health, and human service organizations to be able to provide highly coordinated and effective care to improve outcomes across populations. The adoption of HIEs and interoperability has come with many challenges and lessons learned over the course of the last several years, with many considerations and best practices to support organizations in being successful with these technologies. Organizations often need to strike a balance between sharing data for the purposes of coordinating care and providing effective care coordination, that being balanced against protecting client sensitive information with regulations such as 42 CFR in the substance use disorder space. Our presenters today will shed light on what successful HIE adoption looks like. We have an excellent lineup of presenters for today's session. Mohamed Shibli is the Vice President of Solutions at Nextgen Healthcare, where he works directly with healthcare organizations managing enterprise application design, development, and implementation of HIT and EHR systems. Mo started with Nextgen as an interoperability project manager, where he later became senior in that role. After he was Director of Product Management, he shifted into the vice president role. Prior to working for Nextgen, Mr. Shibli worked for MTBC, where he most notably was their vice president of information technology. Thomas Therio is a part of the professional services team at Highbridge Solutions. Tom is a serial entrepreneur with over a dozen successful product and company launches in the fields of Uber-like services, healthcare, consumer goods, entertainment, and business solutions. He is an expert in the field of user experience design, software development and marketing, as well as other areas of expertise. He has served in the US Navy and in senior executive capacities, combining innovation, marketing, engineering leadership, and program delivery. Last but not least, our presenter, Cameron Fletcher, is also part of the Highbridge Solutions team, working in professional services. Cameron is a skilled software developer with extensive UX and UI user experience, design, and project management work. He has contributed to the successful release of many projects whose dedication and insight ensures an outstanding product is always delivered on time. So our hope today is that you leave the presentation with an understanding of the importance of interoperability with coordinated care, the difference between data exchange and interoperability, and really an understanding of all of the stages of interoperability. So with that, I'll go ahead and turn it over to Mo Shibli.
Thank you so much, Melissa. Thank you everybody for joining, and we're really excited to have you here. The topic about interoperability is one that is very close to my heart. It's a space that I've been working in for a very long time. Helping providers and organizations share and exchange data is really critical to the entire healthcare ecosystem. And it's often just a cliche to say that we work in healthcare and we are all patients. But the reality is that until you go through something where you need to be able to access your data, until you have multiple providers working on your case or helping you accomplish healthcare goals, it's really sometimes hard to see how interoperability can break down between different settings of care. So the goal for our session today, as Melissa said, is we're going to try to outline some of the capabilities that exist today and really understand how we can apply interoperability principles to the exchange of clinical and behavioral health data. Another cliche is starting with a definition, right? So I'll just start with really the interop definition that was outlined in the 21st Century Cures Act. 21st Century Cures has really gone a long way to accelerating interoperability in healthcare by defining it in a way that's useful for all aspects of care. And there are three real parts to this definition. The number one, the enablement of secure information without special effort. This phrase is critically important, that participants in the healthcare ecosystem, whether you're a provider or a payer or a patient or a hospital or a lab, they must be able to exchange data with one another and with all of the necessary stakeholders without special effort on part of the user. This gives us the impression that interoperability has to be built into the capabilities that we all provide. Number two, interop has to provide complete access to the clinical note, the records, all of the information. We have now kind of an expanding definition of what has to be part of that clinical record. 21st Century Cures started off with the definition of for EHRs, especially the US core data for interoperability, the basic set of clinical elements that have to be shared electronically in a repeatable, automated type of way. We're expanding that definition through the course of the next few years to include all electronic health information. EHI, as an acronym, is now coming into more prominent usage. This idea that the full electronic health record has to be made available in interop, and again, without special effort on part of the user. The third core part of this definition, one that's critically important, is this idea of not constituting information blocking, right? And so if you've been around the space for a long time, you may have said, the way I've said in the past, that, you know, EHRs don't speak the same language, right? EHRs can't share data. We don't have standards. These are all kind of the tropes of reasons why interoperability and data exchange was, you know, prevented in the past. But going forward with with 21st Century Cures, the idea that we cannot block the sharing of data either by policy or by technology or by any kind of arbitrary reason, unless it meets one of a small number of exceptions that are laid out in 21st Century Cures. This definition is an important working model to keep in your mind as we move forward through the rest of the conversation, right? And we should not and won't be distinguishing necessarily here in the definition phase between, let's say, clinical data for an ambulatory practice or even behavioral health data for a substance use treatment center or a therapy organization. The ideas around interoperability are going to apply universally, but of course there are exceptions and limitations that we're going to get to and ways to control the data. So now that we have kind of a working definition of interoperability, how is interoperability actually showing up out there in the universe today? When I think about interop, I usually think of really four key things. I think of the transactional data exchange, the meat and potatoes of interoperability, right? Orders and results and immunization registry and prescription drug monitoring programs. I think about capabilities like data aggregation. If you have more than one organization that is contributing clinical data for a patient's record, you know, organizations sometimes need to build up a longitudinal view of a patient's content, and that is really kind of around the HIE space. Number three, as a major category, I would say are APIs. APIs today are the primary way that developers want to connect to health information systems to build new apps, to add new services, and really exchange capabilities. So transactional data aggregation and APIs. And then finally, maybe the most broad set of capabilities on a national level is this idea of national interoperability. Those networks like Direct Trust and Care Quality and SureScripts Record Locator that operate, you know, in all geographies, in all zip codes. And so interoperability what in the old days maybe just one, point-to-point interface that facilitates, a system A connecting to system B. This model is a lot more complicated than a simple A to B situation in today's world. And so we have to acknowledge that there are a lot of different facets of interoperability, a lot of different connectivity spaces. And one that maybe we often forget or leave out is the necessity to, connect to medical devices and other kind of in-office tools that help diagnose or treat or track a patient's condition. So I want to paint a very broad scope of where interoperability lives in healthcare today. And now I'm going to deep dive a little bit into some of those more common mechanisms for how organizations are actually sharing data. And then I'm going to paint the picture of the tools that you can add to limit and control and manage for sensitive data that is required for integrated care and behavioral health practices. So one of the most popular mechanisms today is direct messaging. Direct messaging allows, Dr. Jones, the A, to communicate with Dr. Smith, the B, of the previous, scenario that I laid out. A to B connectivity is still really important, but how do we do it on a national scale? We do it primarily, or one of the key ways is with direct messaging, which is a push of data. It gives a provider the ability to send an unsolicited message to another provider. And then everything in the middle, the technology pieces in the middle, are where things like identity validation and security and the certificating, where all of that happens. And so today across the whole country, there are more than 2.5 million recipients that have been exchanging clinical records in this fashion. More than 2 billion direct messages have been sent from provider to provider in this way, using direct trust accredited technology. So that's a push of data, sending from one system to another, one provider to another. Very common for things like referrals and pharmacy administered vaccines and those types of things. Well, there's another mechanism that's really important to know about, and that's a pull of data from one system to another, the ability for an organization, here system A, to query and retrieve data from system B, right? And so how do we get an organization to query and retrieve data? You have to actually do a little bit of a dance. You have to ask first, do you have a record for this patient that I know about? And that responding system has the ability to say, yes, I have a record, one and only one record for this John Smith patient. And then of course, the next step of the little dance is to say, well, can I have a copy of that record? And for that record to actually be successfully transmitted. So this idea of pulling data puts an organization more in the driver's seat, right? Where you're not simply waiting for an arbitrary provider to send you information. You as the organization have the ability to reach in to a hospital system or an ambulatory practice or a specialty clinic and get a copy of the record. On top of this workflow is a service provided by SureScripts, which is a clinical record locator. So it tells you who potentially may have clinical records for your patients. So it's a really important, idea that we have push systems like with direct, and we have pull systems with care quality. And, frankly, these are really becoming the most commonly used mechanisms to share clinical information. Every vendor on this left-hand side of the screen is already live and either directly an implementer themselves, or they've implemented other organizations, right? So technology providers that enable connectivity for other sites as well. And then, so we have push, we have pull, and then I would also add, we have community connectivity through an HIE. This is the idea that we can aggregate clinical data in a regional or a local geography to share the minimum necessary. So in a scenario where you, let's say, are an organization, an A, and you want to connect to a B, let's say like an Epic hospital, there's certainly ways, like you saw in the previous diagram, to go, point to point and do bidirectional exchange. But there are also ways through the HIE where through both of these connections to a centralized place, a C, you can both connect and exchange clinical records. The difference being that now the HIE has a universal view of what everyone's records look like. And the HIE can add on top of this analytics and metrics and best practices and alerting and all kinds of proactive services that go beyond just the simple basic, here's a document, send to a recipient, and so on. So HIEs are becoming a lot more dynamic, especially around including new endpoints, right? So in a scenario where A wants to connect to B, often, you end up with a problem where if you don't have an HIE in the middle, right, you need to establish your own connectivity, right, to as many organizations as you may want to connect to, right? And eventually this becomes a very difficult problem for an organization to scale as they're adding more and more partners. The HIE offers that entire service so that every participant on the network doesn't have to build their own, one-off connections. And so as I bet you're thinking, okay, Mo, you've described all these different ways to share data, but from a behavioral health perspective, or an organization that treats, let's say an indigent population, an FQHC population, or a homeless population, you often get into a scenario where how much data can we actually share? Does the data provide the necessary protections so that we can really maintain control over our clinical content and not overshare information? So how do we protect the data within an EHR? And many EHRs have these capabilities. Of course, though, I work at Nextgen, and I think a lot of the tools that we bring to the table are very well implemented and robustly supported across our client base. So, and I think we do a very good job in how the sensitive data can be controlled. So I want to walk through just a handful of examples here. Number one, every service that we've talked about, allows you some level of control depending on what type of interface it's for. So you have the ability to opt in or opt out at a practice level. So within Nextgen, and many other EHRs may work in the same way, you might have an entire organization, right? Your whole enterprise could be on one database, right? And then within that enterprise, you may have multiple practices. So you may have a behavioral health practice, you may have a clinical health practice like an ambulatory or a cardiology group or something. So some organizations, they create a distinction in their system between different types of practices. So BH and ambulatory can be handled separately. We allow organizations to turn on interop services at a practice level. So you can have one level of control or opt-in status over here and a different level of control or opt-out status over here. And that's a really important practice level activation that systems can implement. The other one, of course, is universal across, many of our interop services, then an option to opt patients out, record that opt-out, and then most importantly, enforce that opt-out when an external party requests data from your organization. We have the ability to include sensitive encounters or even flag specific things like meds and diagnosis and problems as sensitive, and additionally lab tests. So there's a really deep level of control that's available to organizations at a granular level to control what gets shared and how much gets shared at a patient or a practice or an organization level. So patient opt-outs, one of the most important aspects of interoperability is, universal, whether you're an ambulatory organization or behavioral health. And that's really the ability to record a patient's preference to share or not share. And our consent module within the EHR allows really easy visualization for front desk administrative users to say, is this patient opted in to this external system of sharing, the care quality network? We can record a consent, we can expire a consent, we can share a document, and it can also be, let's say, overridden in certain break the glass scenarios. So consent recording is just as important that it's useful and easy to understand and visually, clear as it is on a technology level to enforce that consent permission. The other really important one is this idea around sensitive encounters. You may have an entire history of treating a patient, but maybe during one of the recent visits, the patient discussed something that was extra sensitive and didn't want their other providers, to have this information, or didn't want it to be shared electronically. And so we now have the ability to record, identify an encounter as a sensitive encounter, and then prevent the sharing of that data for sensitive encounters across specific interfaces. So users can just right-click and then update the sensitivity settings at an encounter level to suppress the sending of that data to a patient portal or outreach actions based on that data, and also the clinical exchange of that record through services like care quality. And universally across the EHR, we have this idea of a content exclusion list that for things like meds and diagnosis codes and problems and procedures, you can say that depending on the network you're connecting to, there are certain things that you don't want to share. So I never want to share, let's say, my BH meds, right? I can just literally create a list that automatically excludes those meds, and they'll never be produced in a CCDA so that it could be visible to a downstream provider. Now, of course, in this situation where we're being at an edge system like an EHR, where we're being protective of data, you may also want to provide a notice in the document to a potential recipient that, hey, there may be more information that we're not including, right? So without saying on a CCDA that we've excluded Zoloft, right, that itself would be an indication that this patient is taking Zoloft. When a content exclusion list is applied in the CCDA, we're producing a note that says there may be other items, or for the rest of the information, please contact so-and-so, right? And so it's an indication to the recipient, and if you choose to have this or not, it's an indication to the recipient that there may be additional info that's worth knowing about a patient. So think of everything that we've just talked about at the ambulatory organization level, right? I want to paint a brief picture before I hand it off to Tom and Cameron to talk about some of the tools that are available for an HIE to protect data with Nextgen technology and Nextgen services. So remember the problem that an HIE has, which is fundamentally more expansive than a problem that an ambulatory organization has, right? All of the ambulatory organization concerns around sensitive data inclusion, around the merging or mixing of behavioral health and ambulatory data, all of that is now abstracted one level up and made more complicated when you've got data from multiple organizations. So what are some of the tools that are available for an HIE to protect their data? Well, one of the things that we have is an idea in our HIE platform of something we call a patient aggregate, which is all of the clinical content that we might know about an individual patient. It's meds and allergies and patients and diagnosis codes and documents. And we have to be able to add these data protection layers on top of it, the ability to control who can access that data, the ability to manage confidentiality, to enable privileges, to enforce and record consent. And all of those optionality of security layers are handled through role-based access at a user level for the HIE. And what does that look like? Well, it means that users of the HIE may have multiple roles that allow them to see, one that lets them see medications, one that lets them access CCDA documents, and so on. So users can have multiple roles to access the patient aggregate, all of the clinical content that comes in from an entire community worth of data, whether it's a behavioral health organization, or a substance use treatment center, or just an ambulatory PCP. The important step that most HIEs take is that they identify certain data sources as protected, meaning for the data from this source, we want to handle it in a more secure and more identifiable way. So data from protected sources can be segmented, right, to enable an additional layer of security beyond the ambulatory, hospital, or lab data so that we can handle protected data separately. the way this shows up in roles is that we create in our platform the ability for us to share or not share a non-protected view, meaning just an ambulatory hospital lab type of view, versus a separate view of a patient's data that includes all of the BH and substance use treatment data, the Part 2 data. And this type of configuration of identifying sensitive sources and also being able to segment the data for different types of users who may or may not have access to Part 2 data is a really critical step that HIEs take. Because I'm sure, as everybody on this call knows, the moment we start collecting or accessing or recording Part 2 data, we now are subject to additional regulatory rules around redisclosure notices, around audits, and around messaging back to the original source system to let them know that their data has been accessed. So it's really critical at the time of designing a system or choosing to activate an interoperability service that you've thought through all of the different parameters for how you want to control the exchange of data. I hope that in this brief kind of introduction and conversation around interoperability and sensitive data, that at least you are encouraged that there are additional and new and expanding sets of abilities for organizations to exchange comfortably, exchange sensitive data, to be able to document the clinical content that should or should not be excluded, to opt patients out and record and enforce the consent, and then to turn on or turn off services, at a practice or an enterprise level. All of these tools exist in different levels of maturity across some and many EHR systems. And we definitely encourage you, if data sharing, if recording and enforcing of permissions is a challenge, if managing, behavioral health and ambulatory data within one system is a challenge, I believe there are really excellent solutions out there to help make your experience easier. So with that, I want to stop here and turn it over to Tom and Cameron to walk us through, from their perspective, at the HIE perspective, some of the opportunities and challenges and how they've worked at Highbridge to simplify the exchange of health information for their communities. So Tom and Cameron, over to you guys.
Thanks, Mo. What a great job. And Mo is one of the reasons why, when we were searching for a new HIE platform, we selected Nextgen because of the just tremendous technology, and the experience that's gone into this platform has just been amazing for us as we rolled out this new health information exchange for the state of Georgia. Highbridge HIE is committed, basically founded in 2015, to helping providers located in rural and other underserved areas to access comprehensive patient information as leading-edge technology that previously wasn't available to them. The HIE is led by Dr. Dominic Mack, who's the executive director, and the director, Carmen Hughes, who's the executive director. It's housed at the Morehouse School of Medicine and the National Center for Primary Care in Atlanta, Georgia. A great organization and really serving a really great segment of the population. So one of the things that we provide really is technology and clinical support services to help these smaller healthcare providers deliver a better patient care while receiving the same benefits that a larger healthcare facility would have. And what's interesting, for us is that we now are able to provide a wonderful set of services for these providers that were really unattainable for them just a couple of years ago. We're able to, through the Georgia Health Information Network, we're one of 4 regional health information exchanges in the state of Georgia. And that allows us to connect to a variety of providing networks so that we can provide a sort of an aggregate patient visibility, right, for a provider. So we've got our community health networks for hospitals and ancillary services. We have integration with the correction facilities within the state of Georgia, physician practices. We begun an EMS first responder a record delivery network, and of course, the great hospitals that the state of Georgia provide. Our technology through Health Data Hub allows us really to connect to any EHR system. We have no preference for a technology. We're an open platform, obviously. We run on a public-private partnership throughout the state of Georgia. And the Highbridge system is not sponsored or operated, by any health system. We're an independent organization, and we're sort of housed within the Morehouse School of Medicine. Some of our connected organizations throughout the state, if you remember, we serve, the small and sort of perhaps underserved community. And, that takes into account sort of small independent practices, small independent hospitals, rural communities, underserved communities, and just those in greater need. And if you're sort of in that sort of population segment, you're basically in an island. And this is where we come into play to connect them to the great state of Georgia's wonderfully connected organizations through state agencies, the large health information systems, the other three HIEs, I should say, the care management organizations. And then, of course, we can reach out nationally as well through the National Health Exchange. Okay. So one of the things that we sort of pride ourselves on is that we do serve the single physician practice, but then we also have, mid-sized practices as well as the statewide correctional system. We're providing records for them, as well as a national geriatric residential treatment facility. So we can really scale with our clients and their needs. And one of the great things about the Nextgen Health Data Hub and being an HIE, we're able to work with and understand what their unique individual needs are and be able to create products and services to help them treat their patients and continue their mission to serve their patients. So the patient aggregate is really important for us. Being able to segregate and secure data through the Part 2 is really important for us and for our clients as well. We need to be able to secure this data and the access per provider, per location. So the Health Data Hub has really helped us tremendously. Some of the services that we do provide, like I said, we do connect with pretty much every EHR. We're agnostic when it comes to the EHRs. One of the large asks from our community is for alerts, ADT alerts. This has been a hot topic for our providers. They're really wanting to know what's happening with their patients. Are they being admitted? Are they being discharged? Have they been transferred? They want to know this information. And so we're rolling that out as we speak. Lab results, lab orders, those types of things. Those are, we're providing that service as well. We're also delivering clinical decision support and also medication support as well. So through our integration with Dr. First, we're able to provide medication prescriptions, what's happening with that patient as well. Okay. Some of our other core services, obviously, we want to provide a single source for our providers. So we're connected throughout the state of Georgia. We're able to sort of coalesce all those records and provide them with one single view. And then also we want to be able to provide consent, meaningful insights, and be able to provide a custom view to their patient record based on their needs. So with regards to that, we want to provide special product services like reports and other search generation capabilities. Okay, and with that, I'm just going to let this Cameron talk about the levels of connection and what a typical EHR connection looks like.
Yeah, absolutely. So when we're talking about connecting at various different levels and different sizes of practices, we really had to come up with different offerings that are best suited for what that practice will need. So when we talk about the small single physician micro practices, access to them means access to a portal EHR, such as Health Data Hub. But then when you start to scale up to the more enterprise level clients, like the correctional facilities that we work with, or the national facilities, they need refined workflows that are built into their existing systems, because it would take more effort to introduce a new tool into their workflow than to, just work with the one that they already have. So when we kind of talk about our levels of connection, interoperability can look at this is interoperability at kind of every stage of growth and scale. First, starting at the kind of smallest scale with just access into the network, so that a physician can search for a patient's record within the portal without any sort of development needing to take place. They can look up the patient's record and view their aggregate that we're able to pull, and then do with whatever that information with whatever's relevant at the point of care. So they perhaps might download that document and import it into their EHR if their EHR supports that capability. But they also might just use the portal viewer as kind of just a clinical viewer that is auxiliary to their treatment at the point of care. Level 2, Mo kind of touched upon. This is kind of a bidirectional connection to an EHR, where we would allow data to flow in and out of the EHR from whoever we're partnering with or whoever we're connecting with to us as the HIE. And so the benefit of this kind of connection is that when we're talking bidirectional connections to an HIE, you're not only gaining access to just the HIE, but all of the connected participants of the HIE. So it kind of eliminates that problem that Mo illustrated, where you've got practices A through F, and you've got another practice trying to connect to all of them. We as an HIE kind of step in the middle and allow that kind of federation step to be placed on our shoulders, along with the maintenance that goes into interoperability. Level 3 is a little more involved, and this is where we as an HIE typically sit down with your EHR vendor to better enable patient querying right in your EHR. So we've seen this take all shapes and sizes. It might just be a button on the patient's chart where you can click, pull information from the HIE, and then your EHR just handles in the background performing all of that automation and getting that record and bringing it into the chart so that the physician or the provider can, interact with it at the point of care. And this is really where we're trying to drive a lot of our practices, where it makes sense, is to get them so that, we're not asking them to modify their workflow. We're trying to integrate as deeply as we can into their existing systems so that there's more utilization of the HIE. People are resistant to change, right? So then finally, level 4 is full automation with things like scheduled querying and automatic notifications. This is really better served for the enterprise level clients such as our correctional facilities who have perhaps hundreds of patients having intake processed a day, right? So we really work with them to make sure that we've got all of those queries scheduled and sent out in batches, and they come back when they need that information. And there's not really anyone on their side that's doing anything special to interact with the HIE other than just business as usual. We kind of handle that all in the background. So kind of focusing and zooming in on that third level of interoperability, this EHR integration. This is what we most commonly see with the practices that we integrate with, is really where office managers and physicians and people who are going to be interacting with patient data at the point of care, they want that integration to be right into their EHR. They're familiar with that user interface. They're familiar with how that works. So it's easiest for us to just kind of place a button in there, or perhaps a different form that they fill out to get the information they need. And so this is very similar to the diagram that Mo used earlier, where we see the HIE integration kind of nestled into your EHR. And what that enables you to do is to transmit patient documents through the HIE, and you can really see the breadth of the network that and the information that you have access to between, in our case, the state of Georgia. The state HIE has many partners. You saw that big long slide filled with connected partners, which even stems out into the national level, where we talk about medication history or the eHealth exchange, neighboring states. Then Additionally, we have our kind of vendors that we interact with, like Dr. First, for access to data that's coming from national pharmacies through SureScripts. So that's medications, prescriptions, information revolving around that type of clinical data. And then we also have connections to our other HIE members. So when we're talking about a specific geographic region that you might be interested in or that we might be connected to, if you fall into that region, then you'll also receive documents from other practices, maybe specialized practices or other PCPs in that area. And that's really where the rural and underserved communities get to kind of shine through, where, you know, we're going to these isolated, as Tom said, kind of islands of data and linking them up to each other so that not only do they have access to information at statewide and national levels, but they also have access to data within their own community that they may not have had access to prior. So this is really in a broad sense what interoperability is and looks like in the modern age.
Thanks, Cameron. So really, that's how we're new to this the HDH platform. We've been up for about a year now. We're bringing in our partners and they're connecting, and we're getting everybody online. We're moving data in and out. They're very happy. We're very happy with the platform. It's very extensible. We've got big plans for products and services for our providers, both big and small. And we really couldn't do it without the health data platform. It's really great. So with that, thank you.
Thank you. Thank you so much to all of our presenters, Mo, Cameron, and Tom. We invite you now to submit your questions in the Q&A panel on the right-hand side of the screen, and we'd like to move into Q&A.
Hi, everyone. This is Sharon Hicks from Open Minds. You'll pardon me if I'm not on camera, but I have been monitoring the questions, and we do have a few, so I'm going to read them through, and then if anybody has other questions, please, as Melissa said, please feel free to put them into the text box. So the first one is for Mo and Melissa, which is, what do you think is the first step that a behavioral health practice should take when thinking about sharing data through an HIE?
Melissa, do you want to take a crack at that, or me to jump in?
I mean, I think that you do. The first thing that you need to do is think through your different programs and service lines and any regulations that may have implications when it comes to interoperability and data sharing. If you have SUD programs, you need to think through essentially the level of granularity that's needed in terms of security and privacy. It's a little bit easier to be if you simply have mental health programs in terms of the data sharing. And so when you're looking at solutions in the market, if you have SUD programs that need to comply with regulations such as 42 CFR, you need to make sure that that solution provider is able to support you so that you're able to stay in compliance. That would be my first suggestion, but Mo, I'll turn it over to you to kind of dovetail on that.
No, absolutely. I think spot on, and understanding kind of the lay of the landscape, the data that you have access to, and also at some point you have to do an assessment of your vendor's capabilities, right? How is this data being stored? How are you recording consent? Do people who are interacting with patients have an understanding of what exchange mechanisms your organization supports? I've often found that there's sometimes a disconnect between services and solutions that are implemented, let's say in the back office, right? We established a new interface or a new connection, but that hasn't been fully rolled out to the front desk folks or even the check-in folks who are communicating with the patient, right? And actually collecting information or updating insurance. A part of that should also be potentially a review of the interop, mechanisms and capabilities that your system has implemented. So educating patients first starts with educating the rest of the staff on what you're connected to, what are the goals for this connection, and then what, if any, mechanisms do you have to allow patients to record their preference not to share, and then how are you going to enforce that? So first, understand that lay of the land, but then also be sure that you have the full education for the entire organization, especially people who are interacting directly with patients, that they should be able to give an elevator pitch about why this connection would be good, or why this connection, what are the options available to the patient for this interface that you just rolled out? I think those are all very important concerns.
Great, thank you. A follow-up question related to that is that in many states, behavioral health services use local codes that are defined by the state as something, but in the national world just mean, something more generic. What kind of translation tools, like, does that come from the HIE, or does that come from your setup of your software to make sure that the definitions are transmitted as well as the codes?
Yeah, great question. I think it starts at the edge system, the EHR, where that data is being entered. Now, there are certain things that an EHR may auto code or auto enforce, right? You interact with a template, and maybe you check a box that says this patient is a veteran. Checking that box should automatically be generating the necessary, ICD or CPT or LOINC codes to add to that record, right? And so that there are certain things that should happen automatically, but that again goes back to assessing the capabilities of your vendor, that stuff is going to be programmed in and understood. For local codes, most EHRs have the ability to do code mapping, right? To record a code based on a trigger event, and that has to be communicated to the HIE, because almost all HIEs have the ability to do a similar code mapping that says, when I see ABC123, that means X. And the HIE has a bigger job, and I don't want to speak for Tom or Cameron, but I'm sure one of the things that keeps them up at night is the concept of a veteran may exist in one code system over here, and the local code system maybe 1, 2, 3, or 4, 5 different ways that other local hospitals may be recording veteran status. The HIE has the added challenge of unifying all of that in a way that is meaningful. And so it starts at the edge system and then just grows as you add more layers.
Yeah.
Yeah, certainly working with the provider, understanding what what data we're receiving, and then we're having to translate. And it's a daily task of looking at those records, making sure the translations are up to date, making sure that new providers where we're getting a complete handle on what we're receiving, so that we can translate and push those records out accordingly.
Great, thank you. For Highbridge, a specific question about the alerts that you were describing. Can you talk a little bit more about them? Like, is it an alert that happens if someone hits an emergency room, or only if someone gets admitted, or can you just talk a little bit about that workflow?
Yeah, so it really depends on the system that we're connected to. So for alerts throughout the state, I know that the alerts that we were referring to is typically admissions. We're connected to quite a few hospitals through the state HIE. And so a lot of physicians are interested in admissions to hospitals or any encounters. It really depends on the setup though. If a physician or a practice is interested in a specific type of event notification, then we as HIEs have a pretty wide array of tools in our arsenal to address those needs. So if there's a specific event that is occurring that you would like notifications for, more times than not, that's something we can support as long as we have access to the data that you need. So typically what we see is people interested in admissions or encounters being added anywhere in the network. So a key kind of component of that is that it extends down all data streams that we are connected to. So if we're connected to a hospital through the state HIE, we'll get notifications for that hospital. We also get notifications from our connected providers and facilities. So if there's an admission in, say, a geographically located or regionalized set of data sources, then you could also get access to those notifications as well. So it really is, it depends on whatever the needs are at a practice level, and then we kind of work backwards to accommodate.
So just to stick with this for a second, there's a standard file called ADT, the admission discharge transfer, that a lot of hospitals send to insurance companies.
Yep.
Is that the kind of thing you're talking about? So because those are like real time as opposed to when you get a claims encounter, which could be 2 or 3 weeks post the event.
Yes, so it depends, again, on the downstream system. When they report the information to the network, then the network will be notified of, in the case of an ADT, that would be real time. So an ADT AO4 notification would be like an admission. Same goes for discharge or transfer. And a lot of the times we get attachments with the actual encounter data. Again, it depends on, some EHRs send out these notifications when the case file is closed. Some of them send at day's end when the practice closes and the EHR enters their kind of routine mode. It's hard to give a definitive broad answer here, but it is widely capable for notifications like admissions, discharge, and transfers to be sent and received in real time along with the accompanying data.
Great, thank you. For the HIE folks for Highbridge, what are your lessons learned about getting providers to opt in? And then specifically, are there questions that specialty providers, behavioral health providers have been asking, before they make their decisions?
So yes, important to note is that Georgia is a by default opt-in state. So you have to opt out in order to stop data sharing. So that is a significantly, that makes it a lot easier on our end to actually receive patient data, because it isn't until they say that they don't want to share it that we have to go in and update that consent. So that kind of addresses that point. As for behavioral health and the specialty and kind of protected data sources, it really depends on a case-by-case basis of what information that particular practice is comfortable sharing. We don't see that kind of data too often, so it really is, we manage it on a case-by-case basis. Most of the people that we're connected with are your primary care physician types, or it isn't usually protected health.
Thanks. And then for the whole group, the last question is, where do you see the future? You've already talked about some of the non-standard data, like data from forensic systems, which is not necessarily coming in through what looks like a standard claim or encounter record. So where do you see the future of, putting a whole person together, their social service history, their intellectual disability services, their forensic stuff that's not part of a general kind of 837 transaction model? Where do you, just envisioning, where do you see the future?
Well, I think from the patient's perspective, that I think you're going to see more patient controls. I think you're going to see wider access to patient data on a plethora of devices, besides phones and, who knows, TVs, microwave ovens, who knows? I mean, it's gonna really, I think, even take a further explosion. I think we're going to see blockchain sort of weave its way into health records and health record management in some way, shape, or form. But I think more to do with patient access to their own data and more control over their data. I think I see that coming.
Yeah, from my side, I definitely think the growth of, there's a saying that I heard one of our product architects say, which is data begets data, right? So the more data you have, you actually end up with more data on top of that that's in place to analyze and measure and monitor and update that data. So one of the key things I think more short term might be that EHR and edge systems have to do a better job of analyzing this entire plethora of data that's moving through the system, right? We talked about push, pull, proactive alerts, sensitive data, behavioral health data. There has to be some broker somewhere that is doing intelligent work on top of this information to minimize the cognitive load at the provider and staff, and then even the patient level, to help understand this content. So I think short term, there's going to be added pressure on vendors like us to build better tools to provide the insights from all of this data that's moving, because the data flow is not going to slow down. Tom said, we're going to expand with patient access and patient permissions and, smart, devices and things like that. It's going to keep happening. But if we don't also add some intelligent analysis and tools It's very easy to get overwhelmed, and provider burnout, patient burnout, everybody's burnout is just going to continue. So that's a call to action than anything else, right? And that's something I think we're very much aware of, and we've got interesting projects to help address.
Yeah.
Melissa, Cameron, any other thoughts from your side that you want to add?
No, Tom and I have had many discussions about this topic and kind of what's in store and what's necessary for future expansion and whatnot. And from an HIE perspective, I think that a word that we use quite a bit is data liquidity. Talking about the flow of data and how easily it's able to get where it needs. And so I think that we're going to see a lot more tooling created and means of interacting with your data, creative to help increase data liquidity and the flow of data.
Now, I would just second that, in that with the new standards for technology innovators and EHRs to be able to not block data, make it more easily accessible with APIs, coupled with the innovators out there in the market creating ways for consumers directly to be able to access their data through apps, I think also through blockchain technology and other kinds of tools. Really, data is going to be where data should be, in the palm of the consumer's hands, so that they are able to be in control of their health information.
Mm-hmm.
Great. And on that note, I think that's the perfect place for us to end this. I thank you all so much for participating. On behalf of Open Minds, I want to thank Nextgen and Highbridge for participating in this webinar, Data Interoperability. And just a reminder to everybody on the web call that you will be getting an audio and record of this, and you'll be able to download the slides for your use within your organization. So thank you all so much, and until next time.
Thanks, everybody.
Thank
Bye-bye.
you.